And good evening, respected Vasi Madam, Professor Vasi Madam, and my dear students. I welcome you all to another session of DNB online academic activities organized by this RAISA WebEx platform. Today we have an interesting FAT exam theory question and answers discussion with Professor Nagaswamy sir. To begin with, Dr. Rafeefa will present anesthetic management of OSA case for laparotomy. Over to Dr. Rafeefa from Miyot Hospital.
Good evening, sir. My question is OSA for laparotomy. OSA patient for laparotomy. OSA is the complete cessation of airflow lasting for 10 seconds or longer despite maintaining the ventilatory effort occurring more than 5 times per hour of sleep with reduction of at least 4% of SpO2. In this case, they are not mentioned about emergency or elective. It is they didn't tell about the obesity of the patient also. They just mentioned OSA for laparoscopy only. So OSA pathophysiology is in OSA will be apnea occurs when there will be pharyngeal airway collapses. So pharyngeal patency depends on the action of dilator muscles that prevent the upper airway collapse. This pharyngeal muscle tone is decreased during sleep and in many individuals leading to significant narrowing of the airway with turbulent airflow and snoring. Increased inspiratory effort and the response to hypoxia and hypercapnia lead to arousal, which in turn restores the patency of the upper airway. The individual then gasps, takes a few breaths and falls asleep again, only for the other cycle to repeat. Pathophysiology can be in case of obese patients, there will be abnormal increased fat deposition in the lateral pharyngeal wall, tongue, tonsil, uvula, and epiglottic fold. Deposition of adipose tissue in parapharyngeal areas, narrow upper airway, which can lead to airway collapsibility. This airway deorients from lateral dimension to an anterior posterior dimension, which put the genioglossus muscle at a mechanical disadvantage in its role in maintaining airway patency and contributing to obstructive sleep apnea. Adipose tissue, if it is excess, deposits superficially in the neck, leads to extrinsic airway compression, and occipital fat can lead to restricted neck extension also in these patients. In these patients, first for in history, in pathology, they will mainly have hypoxia with hypercapnia. This hypercapnia, their hypoxia can leads to bradycardia and arrhythmia. And they will have systemic hypertension due to systemic vasoconstriction, and they can have polycythemia due to increase in tumor TNF alpha, interleukin 1 and all. And they will have excessive daytime sleepiness and intellectual deterioration. And in these cases, due to they will have due to hypoxia, they will have hypoxipulmonary vasoconstriction, which will lead into pulmonary artery hypertension, and which will subsequently lead to right heart failure and call pulmonary. These patients will come with sudden cardiac death also due to vagal bradycardia and ventricular arrhythmias. They can even present with nocturnal myocardial infarction or angina. So when the patient is coming to us in preoperative evaluation, first history we should ask about the stop bank questionnaire, where S is for snoring, T is for tiredness or daytime sleepiness, O is for or any obstructive apneic episodes during sleeping. P is for hypertension, B is for BMI more than 35, A is for age more than 60, N is for neck surface more than 40, and G is for gender, that is male. If the score is 3 to 5, it is milder, 5 to 6, it is moderate, and more than 6 to 8, it is severe. It can be suggestive of severe OSA. Then we can, if the patient is telling about snoring history or obstructive history, we can ask for use of CPAP machine, whether the patient is using daily, whether anyone was advised them, how frequently they are using, whether they are getting relieved with the CPAP machine symptoms, CPAP machine, whether they're getting relieved, symptoms are getting relieved or not. Then we should ask about associated comorbidities like hypertension, diabetes, obesity. We should see whether the patient is obese or not. Then rest all asthma, allergies, everything we should ask. Then in examination, we should see for any obstruction like adenoid tonsillar hypertrophy, macroglossia, retinographia, like airway examination, everything. We should ask any history of GERD is there. Uh, any history of like history of suggesting of arrhythmia, like ischemic heart disease, everything should be asked, and we should ask for effort tolerance also, meds also. Go for CBC first, where you can get to know if there is chronic hypoxia, you will have polycythemia. Then, since the patient is coming for laparotomy, obviously we should do all renal function, liver function, coagulation profile, serial electrolytes, and all. ABG should be done in these patients where you will get a chronic hypoxia with hypercapnia. Then CVS, you can go for an echo and ECG. You will get to know about a right ventricular failure, or where there is a pulmonary artery hypertension, whether there is left ventricular hypertrophy, or you'll get to know. If the meds is less than 4, you can ask for a stress testing. In chest X-ray, also you should do chest X-ray. You can see the position of the hyoid, where if the caudate displacement of hyoid can cause difficult airway, and OSA chances more. And you can even see the pretracheal fascia. If there is more of pretracheal soft tissue, again it's case of difficult airway and more chance of OSA. Then in respiratory, you can go for sleep study or polysomnography, where you can assess the apneic hypoapnea index. That is the number of episodes of apnea or hypoapnea divided by the total sleep time in hours. So in normal AHI is 5 to 10 events per hour. Mild it is 5 to 15. Moderate it is 16 to 30. Severe it is more than 30. You can even see total arousal index, that is TAI, that is the total number of arousal per hour. Then there is called something respiratory disturbance index, where there is both combination of apnea hypoxic index and total arousal index, both you can see. Then overnight recording of SpO2 by pulse oximetry can also be such, because drop of more than 4% is also significant. In this case, choice of anesthesia, since it's laparotomy, it is always general anesthesia with controlled ventilation with thoracic epidural anesthesia. If it is an emergency surgery, we have to take the patient without preparation at all. But if it's an elective laparotomy, you can pre-operative optimize the patient. Like first optimization of the associated comorbidities. Usually, these patients will be obese. They will have metabolic syndrome. So we should have a good glycemic control. If it's hypertension, we should control the hypertension. If the patient is on CPAP machine, we should tell them to continue. If the patient is not on CPAP machine, we should advise the patient to start. We should advise the patient to start on CPAP machine, because if the patient use CPAP machine for 2 weeks prior to surgery, it will improve the abnormal ventilatory drive. If it is 3 weeks, improve the heart function in failure. It will reduce the BP and heart rate due to CCF. If it is 4 to 6 weeks, it will reduce the pharyngeal space. And if the patient is very obese, we have you can go for a liver shrink type, some amount of weight. Then we should we can advise for deep breathing exercise, preoperative bronchodilators can be prescribed. Then CC can always ask the patient to avoid smoking. Then then preoperative, I'll ask for a NPO, informed high risk consent, maybe postoperative ventilatory consent also. Then preoperative, I will avoid opioids. If at all in patient is over anxious, or I have to give a sedative premedication, I will see for a SpO2 monitoring continuous. Then anti-aspiration prophylaxis, DVT prophylaxis, and continued all pre-medications, all pre-operative medication except OHS and insulin. Then monitors which I use will be pulse oximetry, ETCO2, ECG, and NABP, temperature and urine output also. Neuromuscular monitoring and BIS monitoring will be used, because to give titrated doses of anesthetic agents. IBP and CVP only preferred if there is a chance of major where it's suspecting major fluid shifts. Then OT will be ready with all emergency drug, difficult airway cart, including fiber optic video laryngoscopes, LMA, different sizes of LMA, IGEL, McCoy blood, Stilllet, Bougie, tracheostomy and cricothyrotomy kit also. During induction, pre-oxygenation will be before induction. Pre-oxygenation will be done for 3 minutes with an head up position, preferably with CPAP 5 to 15 centimeter of H2O, and preferably avoid sedative pre-medication. A thoracic epidural should be placed according to the level of the laparotomy, whether it's upper umbilical or below umbilical, both for intraoperative and postoperative analgesia. If it is an emergency laparotomy, where the patient will be with full stomach, like perforation or obstruction, patient will be suspended with full stomach. In that case, I'll go for a rapid sequence induction with injection performed with succinyl choline or trochronium with cricoid pressure. If it's an elective case and we suspect a difficult airway, we can always go for an awake fiber optic intubation or a velar laryngoscope. Then short acting opioids like fentanyl will be preferred. Avoid use of long acting sedative drugs or opioids like morphine and all. Dexmedetomidine will be very useful in this to provide a opioid free analgesia because it's both a sedative as well as an analgesic, and it causes less respiratory depression and conscious sedation also. And then the patient will be intubated, endotracheal intubation will be done, and following which non-depolarizing drugs like atracurium or vecuronium will be given. Maintenance, for maintenance, both TIVA, like total intravenous anesthesia with propofol, or inhalation anesthesia also can be preferred. Nitrous oxide is not used due to there is a chance of pulmonary artery hypertension. Epidural will be can be started with the 0.125 bupivacaine or 0.2 ropivacaine during intraoperatively only for analgesia with or without fentanyl. Judicial goal-directed fluid management will be done. Avoid hypothermia, use of forced air warmer. Ventilation tidal volume will be 6 to 8 ml per kg with adequate PEEP. PEEP will improve the lung compliance, less atelectasis, and improved oxygenation. Then at the end of the surgery, I'll extubate the patient only if the patient is fully awake with a patient sitting or reverse central work position. After adequate suctioning will be done. Then after only the complete reversal and complete airway reflexes. If the surgery was long duration, I'll do a delayed extubation in ICU after a few hours. Post-operative, the patient will be nursed in head-up position, 30 degree. Then, if the patient is using CPAP pre-operatively, I'll advise to continue the CPAP post-operatively also. The patient will be kept on NIV. The patient will be nursed in a high dependency unit. Then good post-op, all monitors will be attached, like NABP, everything will be monitored continuously. Good post-operative analgesia with multimodal analgesia. First one with epidural, thoracic epidural will be continued. Second, NSAIDs like paracetamol, everything can be continued. Then avoid opioids and sedative medications again in post-operative also. Early mobilization and early enteral feeding can be done. Floatron cuffs and DVT prophylaxis can be given. Deep breathing exercises and incentive spirometry can also be done. That's it.
Okay. Very good. Why this question has been worded as OSA patient coming for laparotomy?
Maybe because we have to give GA. GA is unavoidable.
Is OSA common only in obese patients or it is present in non-obese patients also?
Non-obese patients, very common in non-obese patients also, sir.
Okay. You have brilliantly described all the points. I totally agree with all your description. Of course, there are one or two missing points which I will point out now. But this question is more or less like a case scenario, isn't it?
Yes, sir. Yes,
A
sir.
OSA patient coming for laparotomy, discuss the pre-op evaluation, intraoperative management, and post-op care. Okay.
Yes,
So
sir.
this should be discussed under the headings first history taking. Okay.
Okay.
So you have mentioned all the points, but they were all jumbled up. See,
Okay,
suddenly
sir.
you are telling about whether the patient is obese or not, whether the
Okay,
patient is coming for emergency or elective. All these things are okay. First, you define what is OSA.
okay, sir.
Then you mention about history taking, because whenever a patient comes for a case scenario basis discussion, you always start with the history taking. Then you
Okay,
do the examination of the patient. Then you do the pre-op investigations. Then you do the optimization. Then you discuss about the intra-op anesthetic management. Then you discuss about the post-op care that you have to offer. So these are the headings under which you have to classify your all the points that you have correctly mentioned into these categories. This presentation will make it much more appealing than saying something about the history, then going for OSA, overnight polysomnography, then coming back to hypoxia index. Okay. So all that should be classified in under these headings. In all cases of clinical scenario discussion, if it is given whether in the theory or in your viva exam, it is always better to group them under these headings. So first definition of the pathology or the disease or the condition that has been described. Next thing you should talk about is the history taking. So in this case, what history you can take, whether the patient has been obese or not, is very, very important, because middle-aged men and women start snoring and go in for mild degrees of OSA. They may not have the classical features of complete obstruction for more than 10 seconds, desaturating, going in for bradycardia and waking up with a startle and having all the features of next morning headache, lack of concentration, irritable mood. All these features may not be present in all the cases. They will all come under the category of a mild snorer. Okay, mild snorer with a mild OSA. So we have to take the history whether the patient belongs to obese OSA category or non-obese OSA category. That is very, very important to say in the history itself. And if it is obese, we can talk all about the management of obese patients coming for anesthesia. Okay. So that is the first and foremost thing that you have to impress in the introductory history taking examination. And in the history, as you have mentioned, if it has been diagnosed earlier and patient has already been treated with a CPAP or a BiPAP machine, you are much more comfortable because the pathology has been identified and treatment has already been started, and all the complications of OSA have to some extent prevented. As you said, if they are already on BiPAP or CPAP, the pulmonary hypertension is likely to be much less, and their clinical behavior is should be much better. They need not have that early morning headache, lack of concentration, and the irritable mood. All these things would have been correctly, cured of all those problems. Okay, but the patient who is not diagnosed earlier and on finding him obese, you ask and find out, then only there is a need for asking him to go for a polysomnography and trying to identify the degree and severity of OSA. All that comes later. Okay. So the discussion should go on like that. It is a very broad topic where they try to test you how you think in various angles when it is given just as OSA instead of obesity. Okay. So the first thing what I would suggest is you classify them into obese and non-obese OSA patients. If it is obese, diagnosed, undiagnosed patients, and then undiagnosed patients pose more problems, so they need more examination and more investigations. So if a patient is undiagnosed, there only your stop bank questionnaire is going to be helpful. If he has already been diagnosed and he is on treatment, stop bank questionnaire has no role in that, because already he has been branded as a OSA patient and he has been started on the necessary treatment also. Okay. So if you discuss in that manner, I think your presentation will look much better
Okay.
and more appealing to the examiners, because you have classified the problem from the clinical angle also, whether a patient is obese or non-obese, whether they are diagnosed, undiagnosed, and undiagnosed, what are all the investigations that you have to see, and what is their BMI, what is their other problems. So if it is associated obesity, you can talk about all the problems, as I told about the mnemonic, a prime minister attending a public function. Okay, airway is a very, very important thing in patients with OSA. Majority of them have a difficulty airway. Okay, so the airway management comes an important role is there. So like that, you have to classify and then try to give your answer, so that you discuss about that. A few points which you have not mentioned is about the this patient, the patient in for induction. Of course, for a laparotomy, GA is a better option. And if the patient is an obese OSA patient, giving an epidural also will be quite challenging. Finding out the landmarks and putting it is not so easy as you say in your theory answer. Placing an epidural, thoracic or lumbar is going to be a challenge by itself. And the RAM position, you have not mentioned that word RAM position is very, very important. And of course, all the gadgets that difficult airway card should be always available. And if necessary, a need for awake fiber optic intubation. That is a very important thing that you have to mention. So in the pre-op examination, if you find that patient, in addition to OSA, also has an anticipated definite difficult airway, the best option will be awake fiber optic intubation. That answer should never be forgotten in all these cases. Okay, even though you mentioned about video laryngoscope, alternate methods, bougie and other things, awake fiber optic, RAM position, these two are very important mentions. And whenever you talk about opioids, these patients are more sensitive to opioids and likely to go in for respiratory depression. You have to use the word opioid-free analgesia, which is the modern concept. So that terminology should be included in your answer. So you must always say, I will practice opioid-free analgesia in this patient. And there is a definite role for ketamine infusion and desflurane. These two agents are definitely very much indicated in these patients. Or even bariatric surgery, they usually use ketamine infusion and desflurane as the sole anesthetic instead of your propofol infusion. They found low dose ketamine infusion and desflurane the ideal technique for obese OSA patients. Okay, so all these points you can include in your answer.
Okay.
And I just share